Hello everyone, thank you for coming. Welcome to this session of NAHDO's 36th Annual Conference. On your attendee screen, you will be able to enter comments and questions in the audience chat. We hope you will take advantage of this opportunity to engage with our speakers. We recognize and thank our Petabyte sponsor, the California Healthcare Foundation. All conference sponsors have virtual booths available during the conference in the sponsors section. At the booths, you can learn more about the sponsors, review materials, request contact, and collect game tokens. We hope all attendees will take a few minutes to visit each sponsor's booth. Now I will turn the stage over to Norm Thurston, NAHDO's Executive Director, who will start today's session.
Thank you, Marin. Good morning, everyone. It's wonderful to be with you on this, the final day of NAHDO's 36th Annual Conference, Rising to the Challenge, Connecting Data with Policy. My name is Norm Thurston. I'm the Executive Director at the National Association of Health Data Organizations. I'd like to begin today by thanking our conference sponsors. Without them, none of this would be possible. We hope that you have taken the time to visit their sponsor booths and leave a little note for them on the live chat and connect with them about resources that they have to help you do your job better. I would like to point out that this isn't NAHDO's only event this year. On November 9th and 10th, we will be holding an in-person workshop focused on networking and connection building at the Hotel Andaluz in Albuquerque, New Mexico. Details and registration are available on our website. Our room block expires on October 15th, and we have a fabulous rate, so we encourage you to sign up as soon as possible. At this point, we're going to present our NAHDO Rising Star Awards.
Hello, I'm Andrea Clark, Senior Analytics Manager in Barry Dunn's Health Analytics Practice Group and a member of this year's NAHDO Program Planning Committee. Barry Dunn is extremely pleased to sponsor this year's Rising Star Awards. At Barry Dunn, we are passionate about development and growth for our own team members, our clients, and about NAHDO's mission to improve healthcare data collection and use through state data resources. Barry Dunn integrates economics, actuarial science, and data analytics to instill confidence in decision-making for healthcare leaders. We offer comprehensive support, including programming, data management, and knowledge of healthcare data and operations integrated into one team with a long track record. And with that, I'll turn you over to Michael Lundberg to introduce this year's winners.
Thank you all for the opportunity to share with you our presentation of the 2021 Rising Star Awards. I am Michael Lundberg, the Vice Chair of NAHDO and CEO of Virginia Health Information. NAHDO's Rising Star term recognizes individuals displaying emerging mid-level talent at a public or private healthcare data organization contributing to the NAHDO mission. A general definition of rising star is a person or thing considered for, is destined for, or currently allowed success in a particular field. The phrase rising star is an English word that came into use in the early 1800s. Well, it seems to me they appreciated their own rising stars. You may wonder, what do rising stars have in common over the years? Well, it's passion, energy, belief, curiosity, authenticity, and positivity. They're all qualities rising stars have in spades. They're motivated by the desire to help people, and they believe in what they do. So, okay, you get it. Let's meet our two winners. Erinn Sanstead is a research scientist for the Minnesota Department of Health. In that role, she works to make data for their all-payer claims database more reliable and accessible to researchers and the public. Julia Tremaroli is the Intake Quality and Policy Analyst with the Center for Improving Value in Healthcare, also known as CIVIC. They're in Colorado. In that critical role, Julia works with data submitters to ensure their submissions to the Colorado APCD are timely, accurate, and high quality. Well, you can find out more about Erinn and Julie on the awards webpage. Both are active with the NAHDO sharing their experiences and benefiting from others in work groups and efforts to share their experiences with others at NAHDO and elsewhere. In recognition of their noteworthy contributions to the Minnesota APCD and NAHDO's mission, we are pleased to present Erinn and Julie as a NAHDO Rising Stars. Thank you.
Thank you so much. This is so exciting. I got to show you what I got. This is pretty cool. I just have to say thank you so much to all the folks who have really allowed me to succeed so far, specifically just the community of NAHDO in general. There's just so many opportunities for collaboration across the community and across states and across organizations, which I've certainly taken advantage of, and I really appreciate all those opportunities. And then beyond that, there's just been some folks at Civic who have just bent over backwards for my success, and I just have them to thank a million times over. So thank you all, and I really just look forward to continuing the work that we're doing to achieve the triple aim and improve the health and lives of both Coloradans and then just folks across the country. So thanks so much.
Erinn Sanstead has asked that I read the following statement. Thank you, NAHDO, for this Rising Star Award, and thank you to the team at the Minnesota Department of Health for being a consistent source of knowledge and encouragement. We have some exciting projects in the works with Minnesota healthcare data, and we look forward to applying the insights learned at this conference. Thank you. Thank you, Erinn, and congratulations. At this point, we're going to hear a few remarks from our sponsor, Molina Healthcare. And we're going to bring out Brian Monson for just a brief introduction to our fabulous federal leadership panel. Brian?
Good morning. My name is Brian Monson, and I represent Molina Healthcare. Molina is one of the national managed care companies whose primary business is government programs. And we're grateful to be a sponsor of this conference today. This session in particular is of great interest to Molina. We have an outstanding panel of presenters, and it should provide for some great dialogue. I think if we've heard nothing else at this conference, we've heard that health data drives everything. And in Molina's early days as a health plan, they literally paid claims through an Excel spreadsheet process. One of my first assignments as I was a new employee about 25 years ago was to go out and test some new claims payment systems that at the time were supposedly state of the art. And to me, they were mind blowing on what they could do. Now, fast forward to today, and as a country, we can dissect every population, every benefit sector within healthcare, and we can pull information that drives what state Medicaid programs do, what legislators do when it comes to funding various programs, and it definitely shapes what the federal government does when it comes to federal policy. And that is the discussion that we're going to have today. So I'm grateful that Molina Healthcare can sponsor this plenary. So on behalf of Molina Healthcare, welcome to the session. So on behalf of Molina Healthcare, welcome to the session.
Thank you, Brian, and thank you to Molina Healthcare for sponsoring this session. We are excited to introduce at this point Craig Schneider, who is our program co-chair. Actually, he's been involved in planning almost everything in this session and everything in the conference. So Craig, we're glad to have you here, and we're going to turn the stage over to you to introduce our panels and to get us rolling.
Great. Thanks so much, Norm, and thanks also to Molina Healthcare for your support. As co-chair of the NAHDO Programs Committee with Kevin McAvee of Minot, and representing my new company, Health Management Associates, also known as HMA, it's my honor to moderate the Federal Leadership Panel for this year's annual NAHDO conference. You know, when developing the agenda for the annual NAHDO conference, there's always great interest in having a dialogue with leaders of federal agencies regarding their data resources, policy, and program initiatives, and how they can collaborate with and can support state health data organizations. I think you will agree that we've assembled an outstanding panel of federal data leaders for today's conversation. Our panel consists of Joel Cohen, PhD, who is the director of the Center for Financing, Access, and Cost Trends, or CFACT, within the Agency for Healthcare Research and Quality. We also have Allison Oelschlaeger, Chief Data Officer and Director of the Office of Enterprise Data and Analytics within the Centers for Medicare and Medicaid Services. And we have Micky Tripathi, PhD, who is one of the few people whose title and agency is the same, as he is the National Coordinator for Health Information Technology within the U.S. Department of Health and Human Services. So we'll begin today by having each of the panelists discuss his or her role and their agency's role in health data, as well as any initiatives that may have implications for state health data organizations. Following their introductory remarks, I'll ask a few questions for the panelists to respond to and offer their thoughts. And so we can now begin the introductory remarks, proceeding alphabetically with Joel Cohen of AHRQ.
Thank you, Craig. I did have some slides. Oh, here they come. All right. Just to kind of organize my thoughts a little bit, but just to give you some idea of what my agency does and what I do within the agency, you can see that this is actually the agency's mission statement. And basically our mission is to produce evidence and create data and make sure that that evidence and data are used and understood by policymakers and researchers and others who are interested in improving the healthcare system. So basically, you know, AHRQ is we don't have any administrative authority. We don't run a program like CMS runs Medicare and Medicaid, or, you know, we don't have any regulatory authority like the FDA to regulate drugs, et cetera. You know, we're basically a research organization. So our mission and goal is to create evidence and findings that can be used to improve the healthcare system. So I put the organizational chart here for the agency, and basically it consists of offices and centers. And on the left side here are the offices are mostly administrative, not entirely, but mostly. And on the right side are the centers, and the centers are more concerned with substantive issues related to the healthcare system in the country. So again, I'm the director of the Center for Financing, Access, and Cost Trends. That is the group that does the Healthcare Cost and Utilization Project and the Medical Expenditure Panel Survey. So we collect data. We also analyze data, and we provide technical assistance both within and outside the federal government. You know, that's essentially, you know, the creation of data, dissemination of data, creation of evidence and findings, and dissemination of that is what we do. The other two centers, one is a Center for Practice Improvement and Evidence, and they're more concerned with clinical issues and primary care and how physicians practice, et cetera. And then there's a Center for Quality Improvement and Patient Safety, and that group is concerned with, you know, quality and safety, and again, you know, clinical areas and how we can improve the quality and safety of the U.S. healthcare system. Next slide, please. So AHRQ actually has a number of different databases and data sources that we collect and disseminate to anyone across the country. We have administrative data, the Healthcare Cost and Utilization Project. That's a collaboration with federal, state, and private organizations that I'll talk about a little bit more in a minute. We also have survey data. The Medical Expenditure Panel Survey is a national survey that my group does. I will talk a little bit about that as well. Our agency also does the Consumer Assessment of Healthcare Providers and Systems, or CAPS. That's a little bit different. It's survey data, but it's a little bit different from MEPS in that the agency doesn't actually do the surveys. We create the survey instruments. Those are done by providers and health plans, et cetera. And then we do collect information and aggregate it so that there's a benchmarking databases that that providers and plans can look at and compare how they're doing with national benchmarks. We also have descriptive data. Our authorizing legislation mandated us to produce a quality and disparities report that we produce every year. That pulls in information from a number of different sources to look at quality issues and trends in quality within the country. And also it's a state, there are state snapshots. So they have state level databases of quality within each state, so states can see what their trends are, and then also how they compare to other states, et cetera. Again, that's an annual survey that's put out, is available on the AHRQ website. We also have some new initiatives, database initiatives. There's a lot of concern about social determinants of health and how you incorporate that into planning and policies. There's not a lot of databases out there, so we have gotten some money from the Patient-Centered Outcomes Research Trust Fund to create a social determinants of health file that can be merged to other databases, that can be merged at the county and zip code level, different variables. So that's available to anyone out there to merge to their own database. We're looking at synthetic data. That's a way of getting very detailed data and being able to disseminate it nationally in a public use database in a way that protects confidentiality. We're also looking at supply side data. This is an area that is a kind of a gap in the federal data resources, and we're looking at collaborating with some state organizations to try to improve the supply side data resources that we have. We're also, one thing that we're thinking about is APCDs and how we can use the skills and information that we've learned by our other, database initiatives to apply that to APCDs, and we have working on some proposals there. Next slide, please. So, well, I'll just keep going because, okay. Just to get a little bit more detail on HCUP, we actually collaborate with state data organizations within 48 states in the District of Columbia to collect their hospital discharge data, which the states collect. We pull it in to our resources, and then we create a consistent database across all the states. So in addition to creating those databases, we have online tools, there are clinical classification software, there are QIs, there are other kinds of things that are quality indicators that we produce, that we put out there. There's analytics, and we also have user support. So we support individuals who want to use the HCUP databases, either the national ones or the state ones, in their own work, and we support that as well. Next slide, please. The MEPS is a national database, nationally representative, 14,000 households. We actually send interviewers out across the country to collect data. There's a number of different components to this. The main household data that we put out, the nationally representative again, is the household and the medical provider component. The medical provider component is necessary because household respondents are very poor reporters of what was paid for their medical care. So in order to get that information, you have to go to the providers. We have looked at adding some supply side information about the organizations of the providers that our respondents used to get some more information about that can be combined with their utilization information to see what how the interaction of the characteristics of the providers and the use and expenditures of the household respondent of individuals determine what happens in their interactions. We also have an insurance component, which is an establishment surveys done by the Census Bureau, and that is actually state representative. So we collect information from every state, from establishments in every state about what is offered in terms of their health insurance, Most people under 65 in the US get their health insurance through their employers. And so we're looking at what the employers offer, how much is paid by the employee, how much is paid by the employer, what the characteristics of plans are, who's eligible, et cetera. Next slide, please. Just to give you, this just gives you some idea of how the AHRQ data are used. The MEPS is used in calculating the GDP and the national health expenditure accounts, which are done by the accountants in CMS, the actuaries in CMS, policy simulation models, healthcare policy decisions. We actually do consulting with different states and their Medicaid programs, et cetera, to try to help them, develop some policies. We worked with Arkansas when they were developing their Medicaid expansion program. HCUP is used in national disasters when we're looking, with the wildfires or hurricanes, et cetera, to look at what needs are following. We look at past information to see, what kind of medical care, emergency department or inpatient care was needed after natural disasters. We also used it to determine the hospital at the onset of the pandemic, COVID-19. There was a lot of questions about what hospital capacity was across the country, how many ICU beds were available, how many ventilators were available, et cetera. There was not very good data out there. And so we used HCUP to provide information both to the federal government and the states as to what it looked like, based on the historical information that we had. It's also widely used for research. So, that gives you an idea of what AHRQ does. And in terms of, what the relevance is for health data organizations, we have projects where we collaborate like HCUP. We provide information to the states. We provide technical assistance, et cetera. And, we're interested in helping them, have the appropriate data and make sure that they have the findings and the information that they need to run their own healthcare system. So with that, I'll turn it back to Craig.
Great. Thanks so much, Joel. We'll now move on to Allison.
Great. Thanks, Craig and Joel. It was a great overview to hear about AHRQ. Super happy to be here to talk about CMS. I'm going to start by talking just a little bit about what we do, which all of you know, but we are the largest health insurer in the country with over 145 million Americans enrolled in the 3 M's, Medicare, Medicaid, and the marketplaces. We also play a critical role in promoting safety and quality in the healthcare system through our Center for Clinical Standards and Quality. And we promote the development and testing of alternative payment models through the Innovation Center. Through running these programs, CMS collects a massive amount of data, and this data is really a strategic and important asset for our strategic vision, which our new administrator has set, which is that CMS is a trusted partner and steward dedicated to advancing health equity, expanding coverage, and improving health outcomes. And our policy leadership over the summer set our 6 strategic pillars. So I wanted to walk through those in case folks haven't seen them. So the first is around advancing health equity by addressing the health disparities that underlie our health system. The second is access to quality and affordable coverage and care. The third is engaging our partners in the communities we serve throughout the policymaking and implementation process. And I think that's really critical. One that's, they're all critical for our administrator, but she's really been out there talking to the communities and trying to really hear from folks. The fourth is driving innovation to tackle health system challenges and promote high-value person-centered care. The fifth is protecting our program sustainability, and I think that's top of mind for all of us with the Medicare program, but also across our other programs, Medicaid and the marketplaces. And the final one is fostering a positive and inclusive workplace and workforce and promoting excellence in all aspects of CMS operations. And really that's about CMS being a best-in-class health insurance company, and health insurer for the people we serve and across our other programs, health and safety, alternative payment models, and the work that my team does. So as Craig mentioned, I'm the director of the Office of Enterprise Data and Analytics at CMS. And our mission is really to maximize the value and impact of CMS data to support informed decision-making by stakeholders, both inside the agency and outside of CMS. And so a lot of our work is focused on disseminating CMS data. And we have two kind of critical objectives that we think about under kind of the umbrella of disseminating CMS data to stakeholders. The first is ensuring that stakeholders have streamlined, user-friendly access to CMS program and survey data in both public use and restricted access formats in compliance with all of the important privacy and security rules that we all have to follow. Just a couple of things under this objective. All of you know that we make data available to state agencies. About 10 years ago, we established a specific pathway for state agencies, including state APCDs, to get access to CMS data. We've also continued to expand the data that we make available to researchers. We're working closely with the Innovation Center right now to continue to grow the availability of data on model participants and beneficiaries that are in CMS alternative payment models. We also recently launched a redesign revamp of our data.cms.gov website, which is our site for kind of finding all of the publicly available data and tools that we release. The second kind of objective under the umbrella of disseminating CMS data is facilitating access to Medicare fee-for-service claims data via FHIR APIs, fast healthcare interoperability resource application programming interfaces. And Micky will probably talk more about this, this area too, but for CMS, it's really about making data available to the healthcare decision makers for Medicare fee-for-service, whether that's patients, their providers, their plans. Many of you have probably heard about Blue Button 2.0. That was kind of our first big FHIR API that gives Medicare beneficiaries access to their own data and allows them to share it with applications and services that they trust. But over the past 4 years, we've launched a number of other APIs. BCDA, our beneficiary claims data API, which supports participants in alternative payment models. A and B to D, which is for Part D plan sponsors to get access to fee-for-service claims data for beneficiaries that are in standalone Part D plans. And then finally, we have a pilot called Data at the Point of Care, which is for providers to get access to claims data right in their workflow, in their EHR. So they could get information, for example, about patients' prescription history. We all know that Medicare beneficiaries have many prescriptions for most of them. And so having that data right at their fingertips for the provider, rather than having the beneficiary have to remember the names of all of the medications that they're taking, we think is critical. And we're excited about where we're going with the DPC pilot. And then just to wrap up, in addition to the data dissemination work, my team also works to strengthen CMS's use of our program and survey data by building our internal capabilities. And so one of the things that we've been really focused on there is building a data science community of practice. We have data scientists and data analysts in all corners of CMS. And like many of your organizations and many other federal agencies, we are a bit of a siloed organization. And so our centers and offices, we're always working to work more closely together. But really the goal with this community of practice is starting to make those connections across the different centers and offices in terms of what data scientists are working on, tools and trainings that are available, having resources that you can go and talk to if you run into a roadblock or have a question. And so we're really excited about the work that we're doing there. So with that, I will stop and turn it back to you, Craig.
Great. Thanks so much. Micky, love to hear your thoughts on ONC.
Sure. Thanks so much. I don't have slides. I'm new to the federal government and I can't figure out clearance. So maybe Joel can help me with that. And I'm going to go a little bit out of order here, just to call out something that Allison said, and just want to give effusive of praise to CMS on the BCDA and the data at the point of care APIs. Those are just fantastic. For those who aren't aware of those, I'm sure we can dive into the details, but those are not only from a technical perspective, just the way we all need to be moving, but from an industry moving perspective, that is the future. And I think that, that CMS is leading the way in really just leading and by example for the rest of the payer community and providers ultimately, but for payers as well, to say this is the way we ought to be making data available for the betterment of care for everyone. So anyway, just wanted to call that out because I think it's just fantastic, and I'm hoping we can build on that and leverage that across the industry. So let me just talk a little bit about the Office of National Coordinator. We do a variety of things. I know in the Q&A we'll get we can dive down deeper, but just to give everyone a perspective on what is it that we do. We are responsible for coordination of health IT activities in the within the federal government, as well as helping collaborate and coordinate and with the industry to help us all move forward with respect to health IT in ways that support the better quality, safety, efficiency, and affordability of care. And we do that through a number of different ways. One is standards. First and foremost, we are sort of the federal arbiter in some ways of health data standards and health interoperability standards as it relates to the clinical side, as it relates to clinical data standards. So we have a bunch of standards that we publish and make available and that are required in different ways by provider organizations to support that are the mechanisms that are used for a variety of use cases with respect to interoperability, and we're supporting EHR systems and a variety of other things. Again, we can certainly dive into that in the Q&A. The other important part of that standards process that we do is we are responsible for putting together the Federal Health IT Strategic Plan, which we publish every 5 years. So that's a coordination activity that we do with all of our federal partners to get alignment on where everyone's health IT roadmaps are and to consolidate that into a plan so that it allows both the federal government as well as the market to understand what are the various activities of the federal government and how are we doing our best to align all of those to give appropriate expectations and help us all move forward together. We also publish what's called the ISA, the Standards Advisory, which is sort of casting the net widely on a wide variety of standards that may not be a part of what ONC does from a regulatory perspective, but it does become a place where any organization who is thinking about using clinical interoperability in some way, shape, or form can use that as a reference guide to understand what's the latest sort of most widely adopted and perhaps most mature set of standards for a particular use case, even if it's not something that ONC requires in any way. So we try to use that as a place where the industry can come together to have an understanding of, kind of a reference, for what our clinical interoperability standards are on there as a way of getting, more and more industry consensus around this. Another thing that we do, so standards is one whole part of what we do. Certification of EHR systems is another hugely important activity. I should back up actually to talk about the two authorities that we have, which really drive everything. One is the passage of HITECH in 2009, which gave us the authority to certify EHR systems, and we worked very closely with CMS. For the Meaningful Use program that many of you may be familiar with. After $40 billion in 10 years, we now have over 95% of providers using certified health IT systems that are certified by ONC and supported and sort of motivated by 17, 18 different payment programs on the CMS side, to have everyone using those in meaningful ways to support better care. So the certification of EHR systems, which is the second thing that I was talking about, is a really important part of what we do, and that's an ongoing process. Vendors are required to maintain the certification and certification status of their systems, and as I said, that now covers 95% of the providers, hospitals, and ambulatory clinicians out in the market today. So it's a very important part and feature of the healthcare delivery system in the U.S., which is otherwise highly fragmented. The third thing we do is we have a number of activities funding innovation and core capacity development. So we do a number of innovation activities, whether it's with PCOR, the patient-centered outcome research collaboration and activities, as well as we have innovation grants that are called LEAP Awards. We just made a couple of announcements, one in particular I'll just point to, which is to the University of Texas at Austin, to have them do some work with respect to referral management for social determinants of health. So building into the EHR workflow, how can I refer an individual for housing assistance or for legal assistance, for example, in the same way that I can refer them to a cardiologist or order an imaging study. And then for those of you who are, Allison mentioned fire. Many of you may not know that the origins of fire actually are in an ONC grant back in 2010. We had a SHARP grant to the Boston Children's Hospital to think about this idea of how would you create a set of RESTful APIs based standards for substitutable apps across different EHR platforms. And that was a $15 million innovation grant at the time. And that led to the creation of FHIR and everything that we're doing today, all the way to the Apple Health Record and, and everything in between. So that innovation, like lots of integration grants, you cast the net widely, you fund a bunch of things, and you hope that one of those really sticks and moves it forward. So we continue to do that. The other thing I would mention there is that we also just announced an $80 million program for workforce development, which isn't directly related to data, but it helps to support our data capacity, specifically in the area of public health for the country. So that program was just awarded to 10 organizations across the country who primarily serve primarily either are or work in partnership with minority serving institutions to train and hopefully place 4,000. I think it's going to be more than 4,000, but our minimum requirement was 4,000 individuals in the field of public health informatics. So it's really looking at the ground level, the issues that we've seen from a capacity perspective as it relates to the pandemic, and how do we start to build that pipeline, and how do we have the broadest catch and broadest opportunity for everyone living in the U.S. and for all of our communities to be able to participate in that and more directly be represented in that really important workforce. So let's see, I've done standards, I've done certification, I've done innovation. Let me talk about coordination. So coordination is a very important activity that we do both within the federal government, as I described the strategic plan, and I can talk a little bit later in the Q&A about specific activities that we're doing to help align federal both data as well as technical approaches to health IT as it relates to health information technology and healthcare. And I think that covers it just from a broad sweep of the various things we do, and very much look forward to the discussion. Thanks.
Great, thanks, Micky, and thanks to all the panelists for those introductions. I think it was really helpful to people to get a broad introduction to what each of the agency does and what your role are, and how all this work connects to the health data organizations that are joining us today. So the theme of this panel is connecting health data to policy. So the first question that we'd love to hear people's input on is,
oops.
Oh, glad it's not just me.
Now, Craig seems to be frozen there.
If we lost Craig, maybe we could just dive into, because I think we all know the first question.
Sure. Go ahead, Allison.
How does data drive policy? And I'm happy to start. So CMS collects massive amounts of data, as I talked about earlier, and it really does drive a lot of our program policy decisions. And I know we're going to COVID will probably be a theme throughout this discussion, but wanted to talk about a perfect example of how we use data to drive our policies with our COVID-19 nursing home data. So we have an oversight role with nursing homes, and we all know that the pandemic has hit our elderly beneficiaries, and particularly those in nursing homes, particularly hard. On a weekly basis, CMS, the senior leadership team, and others across the agency, we review a dashboard that has the latest and greatest data on COVID in nursing homes, looking at cases, looking at vaccination rates. And this really helps our team, our policy team, in collaboration with the scientists and public health experts at CDC, to think about the policy around nursing homes and our oversight role as an agency. The other thing we've done with this data is we've made a lot of it publicly available via our data.cms.gov website, and more recently via a tool on Nursing Home Compare on our Medicare.gov sites so that the public can also find this information, and it helps them make informed decisions about care of their family. So, you know, it's constantly something that we're doing, looking at our data to inform policy decisions. But I did want to address there are a couple things that we're thinking about as we look towards the future. The first is health disparities, and we all know that the data on health disparities, in a lot of cases, the quality is poor or the data just isn't collected. Race, ethnicity, we have that data in Medicare, but we know the quality is poor. On sexual orientation and gender identity, for most of our population, we don't even have that data. So that's really an area we're thinking about. We're also thinking about kind of more modern tools and technologies. So what can we do using machine learning to kind of advance how we're using our data to inform our policy decisions? So Craig, maybe we have you back. If not, Micky, I'll just hand it over to you.
Yeah, sorry, I don't know what happened to my system, but I am back. Sorry about that. Thanks. And yeah, Micky, please proceed.
Sure. Yeah, happy to. So on the question of, how does data drive our policy? It does in a number of different ways. And I'll sort of tease out a little bit. We set policy on data for healthcare, for the healthcare delivery system, and we also use data to inform our policies. So it's kind of twofold. And some of what Allison was referring to is we try to help support the availability of data, unstructured data, so that CMS and other federal agencies can do the the frontline things that they need to do, and that all of us want them to be able to do. So in particular, let me just point very specifically to ONC standards that are in effect today that are called the US CDI, the US Core Data for Interoperability. And for those who aren't familiar with that, if you Google US CDI, you'll come right to our website and you'll be able to see what that is. And what that is, in effect, is it's the minimum data set of the healthcare delivery system. And why do I say that? The US CDI is what's required by all EHR vendors who are certified by ONC. And as I said before, that covers 95% of hospitals and provider and ambulatory physicians across the country. They're required to support the availability of the US Core Data for Interoperability data set for interoperability with for access by patients and for interoperability with other provider organizations. And that's a kind of a rising floor. So what we do is every year we have a process. We just closed out at the end of September our last data call for the next version of the US CDI, where we reach out to industry, we reach out to our federal partners to add additional data elements to the US CDI. And we try to be very judicious in that, because we recognize that we can't dump 50 new data elements on the entire industry, because that's a burden on providers, it's a burden on technology vendors, and all the standards aren't mature. And so we go through a process where we cast the net widely on ideas that everyone has, and then we go through a set of structured criteria to determine which ones do we think are of industry priority, of public priority, and mature enough and feasible enough so that we can introduce those as the next set of data elements that are required. And for those who, just to give you a sense of, how important the US CDI is in the industry, it basically defines what's available to patients. So for any of you who log into a patient portal, if you access your record via the Apple Health Record, the data that you're looking at is actually from ONC requirements and ONC specifications of what data is required to be there and what standards they're required to use. It defines what's available in transitions of care. So to the extent that your provider organization is pushing a continuity of care document to another provider, or is exchanging information over Commonwealth or Care Quality or the Health Exchange, which exchange something like 1 billion records per month via those networks, that again is defined by the US CDI. That is the payload that they are using to send. And so it really does constitute, as I said, it's the minimum data set of the healthcare delivery system. We have a couple of new features that have been added, or new sort of updates to that. One is related again to something that Allison said. In our US CDI version 2, which we published in July, we added 5 data elements and classes for social determinants of health. And that begins the process from a regulatory perspective of giving an indication to the vendors and the provider community that these are going to be required in certification at some point very soon. And so that begins that process of a sub-regulatory process that starts to build into a regulatory process. And as I said, we added 5 data elements for social determinants of health, and we added SOGI data, sexual orientation and gender identity, and the standards that we use to represent SOGI data. And again, if you Google US CDI version 2, you'll find the HHS press release about that. You'll also find the actual data elements for that. So that begins the process of saying, how do we have more uniform approaches to collecting that type of data across the entire healthcare delivery system so that we can get much better abilities to aggregate that information. So first off, to make that information available and to be able to aggregate that information. I didn't mention race, ethnicity, language, and why didn't I? Because that's already a certification requirement. That was already in the US CDI. And ONC requires that EHR vendors support the CDC data set, which we believe is the most comprehensive data set for race, ethnicity, language. It's 900 categories. One of the challenges that we have with that, and Allison alluded to this, is that is required to be in all of those EHR systems. The ability to do it at that level, what we find is that adoption of that is highly variable. And that's why CMS doesn't have great data on race, ethnicity, language. It's not because the systems can't capture it. The systems can capture it. It's because not all providers are motivated equally to use those to capture the data at that level of granularity. So that's something for us to work on with our federal agency partners on how do we get more motivation to be able to sort of use that data and populate those data fields that are absolutely available in the certified systems. The last thing I'll point to in data is we now are in a process with our federal agency partners, CMS and CDC are first and foremost in this, in a discussion of how we add additional data elements to that US CDI to support their agency-specific needs. So CMS, whether it's CCSQ or the Center for Medicare or Medicaid or CMMI, have additional data needs on top of the US CDI to support quality measures, plan design, model design, whatever it is. And we're working with them to say, how do we add those data elements on top of this that can be something that's nationwide and that becomes a part of that sort of minimum data set, but now tailored to individual specific use cases for those who want to participate in those. So that's a whole set of things that we do with respect to data that is a core part of what the healthcare delivery system is required to support and does support. The other thing that I'll just point to is, as I said, we do policy on data for the healthcare delivery system, but also data to inform our own policies. We do a number of market analyses. So if you go onto healthit.gov and look at the data tab, you'll find a whole bunch of analyses that we do there. We have APIs that make the data available in more machine-friendly ways. We have data briefs. We have apps that deliver data on a wide variety of things. We have a team that uses the survey instruments that Joel talked about that leverages data that we partner with CMS on that gives perspectives on what's the adoption of health IT across different parts of the care continuum. How many apps are available in EHR app stores, for example? The answer right now is about 1,000. What percent of those apps are FHIR-based? The answer to that right now is about 40%. How many certified EHR vendors have APIs? That's data that we make available. What is EHR vendor market share in ambulatory and inpatient markets? If you go onto our website, you'll be able to see what share of the ambulatory market does Epic have versus Cerner. And right now, that's the most authoritative data that's available in the market. Why? Because the market is so fragmented, it's really hard to get that data centrally. But because we're working in close partnership with CMS and the incentive programs there, providers who participate in those programs are required to report that data because that's a part of their certification requirements and their participation in those CMS programs. So then the last thing I'll point to is we have a program called Lantern, which now is essentially like a web crawl. What it does is it goes out and actively pings the APIs that are made available by EHR vendors to report back what capabilities do they support with respect to conformance of those APIs, so that we all have a better handle on what is Epic supporting, what's Cerner supporting, and making that data available to the public, so that the public has a better understanding of what is that what's this evolving landscape, and what's capable, what's the market capable of. Let me turn it over now to Joel, I guess.
Great, thanks.
Thank you. Just to answer Micky's question about the slides and approval, the secret is to be from a very small agency and then be the person who approves the slides.
Now I know. Thank you.
Yeah. So yeah, it's not possible everywhere, but in any case, the question is when how data drives our policy. I would say for our agency, it's actually that policy drives our data. As I said, the goal, the mission of AHRQ is really to provide evidence and data that can be used to drive policy. So, it kind of goes the other way around, and we're constantly evolving and trying to figure out, what we can do to provide better information to the policymakers and the providers so that they can improve the healthcare system. So, just to give you a historical example of this, and I'm going to age myself here, and I've actually been around for a very long time, but the Medical Expenditure Panel Survey actually started in 1977 and was done on a 10-year basis. So it was done in 77. There was another iteration in 1987. And we were actually gearing up in the agency to do another one in 1997. And at the time, there was a change of administration, and the Clinton administration, which is several administrations ago, came in, and one of their big pushes at the very beginning of that administration was to do something about the healthcare system and healthcare reform. And so there was a huge, gearing up, and they got a bunch of people together, a bunch of feds. They had all these work groups, and they were poring over what to do, how to redesign the U.S. healthcare system in a way that would work better. And so they were looking at, okay, if we have a policy, how do we know what the impact of that policy is going to be on the system? And so, in order to do that, you have to have information on, what's being used, who's using it, how much it costs, and then you can model what would happen if you change the system. Well, as it turned out, this was in the early 90s, and the most recent data that was available to do that was the National Medical Expenditure Survey, which was the MEPS of 1987. It was already out of date by the time they were, trying to do this modeling. And so, essentially, there was a recognition that we didn't really have the data that we needed in order to do the kind of estimation and projections that we needed to do an appropriate, a job of figuring out what changes to the system would be if you changed policies. And so, we were gearing up to do another one of our 10-year surveys. We actually moved it up a year, and it became, instead of an every 10-year survey, it's an annual survey. So it's a rotating panel design where we pick up a panel every year, follow people 2 years, et cetera. So over time, we've actually built up a huge amount of data. And we are now going into our, I think, 26th year of data collection with MEPS. And when the Affordable Care Act was being talked about within the federal government, the MEPS became, the data that were used in order to do the modeling and figuring out, what was going to happen with the system. In my early slide, I said some of the uses, all of the microsimulation models of changes to the healthcare system use MEPS data. And we actually do work closely with CBO in their modeling to see what happens with the system. So, that's just an example of how, policy, as it moves along, drives what we do with our data. When the agency was created, there was a recognition that there wasn't good quality information about the U.S. healthcare system. That's where the Quality and Disparities Report came from. Some of the social determinants of health file that I talked about, there's been a recognition lately that, 85% of health outcomes are determined not by what happens in the doctor's office, but by the social conditions that people live in. And so, there's been a recognition. So we're putting those files together. So basically, that's what we do. Every year we get together, we gather ourselves, we talk about, what's needed, we make proposals for what we're going to do with data collection. The HCUP data has become very important recently, with the pandemic and all of the natural disasters, et cetera. We try to, evolve what we're collecting there to address those issues. We try to figure out what issues are going to be in the future, and the data then follows what we think, we're going to need, what information we're going to need in order to make good policy decisions. So, in essence, that's the way the agency works, and that's the way we approach that. I'll turn it back to Craig.
Great, thanks. So I'm gonna call a moderator audible here and see if we can combine questions 2 and 3 on our outline, because there's some great questions coming in from the attendees in the chat, and want to see if we can get to 1 or 2 of those questions. So when we're responding about how does policy determine what data you collect and then how you disseminate it, if as part of your response, you can also discuss how COVID has affected your data policy collection and dissemination. And we'll start this question with Micky, please.
Okay, sure. Couple things. One, again, since we're not a frontline organization, we don't normally get data, but we have a tremendous amount of influence in what data is made available by others and other sharing of the data. So let me just touch on a couple of things. One, the 21st Century Cures Act, there's this question of, how does policy determine what data we collect? The 21st Century Cures Act does have some requirements for us in terms of collecting data, like the EHR reporting program, which is kind of like post-market surveillance of systems. So that required that we actually have ways of assessing what's the performance of EHR systems out in the field after they've been, out in the market. And so we're now developing, and we're writing a rule that will, sort of respond to that requirement to collect more data from EHR systems, as I said, in like a post-market way. For those who are interested in that, we did have a discussion with the HITAC, our Federal Advisory Committee. If you Google HITAC, HITAC, I think it'll quickly bring you to the meeting where we, had some discussion on that and the different perspectives that the HITAC offered on how we might think about EHR reporting. The other thing I'll point to, and this is more in the context, it is 21st Century Cures Act, but it's more in the context of what actions we are taking that actually influence the data sharing that happens out in the industry, is that one specific aspect of HITAC is it said that data needs to be made available to patients and other authorized parties through APIs without special effort, was the exact term they used, without special effort. And so we have, so for anyone who's not aware of what's going on there, it's actually a hugely important transition for the industry. One of the things that it says is that it kind of complements and in some ways flips the paradigm of HIPAA-based availability of information, where HIPAA basically said the provider organizations are permitted to make information available without patient consent under certain circumstances, but it didn't require it. 21st Century Cures comes along and says, actually, it's not just permitted, you're obligated to make that information available, not just to patients, but to other authorized parties who are participating in care under treatment, payment, and operations. And so that's a complete paradigm shift for the provider organizations. That went into effect on April 5th. So the law went into effect in 2016. For a variety of reasons, it took a while to get that out, but we came in and we said that that has to go into effect. So April 5th, that went into effect. That has a number of implications now as we think about the motivation now. Providers are required to make that information available, as well as their vendors. So it also names vendors as being parties to this. And it also, from the ONC rule that went into effect, specifies a couple things. One is it says that FHIR APIs must be made available by the end of 2022. And between now and October, provider organizations are required to make available the data that's in that US CDI, that US Core Data for Interoperability that I talked about before. But then after October 1st, 2022, they're required to make available all electronic information to other authorized parties, what we call electronic health information. That's structured data, unstructured notes, whatever is in that electronic health record that's a part of the HIPAA designated record set and is electronic. That is a huge sea change in the industry. And I think all sorts of opportunities will flow from that as we start to think about the availability of information and what other parties are able to do with that structured and unstructured data that's a part of that. Let me just talk a little bit about COVID. Again, we're not a frontline agency, but we are doing a lot of work behind the scenes to help with data flows. We're working directly with the CDC in partnership, part of it through an executive order on public health data systems and having a data-driven response to public health crises in the future. We co-lead a cross-agency work group on that. So we're examining, as a part of that, we're examining all data flows for public health and trying to re-envision what the future system might look like, or future systems should look like there. And there are a number of different dimensions to that. Again, happy to go into more details. And then the other thing that that isn't that actually you might not think is directly related to the pandemic, but it is made health equity, the pandemic has made health equity a front and center consideration for us. Because one of the things I think all of us knows is that we were not able, it took us a long time to, with data, be able to identify that different communities in our country are being affected differentially by the pandemic, both with respect to diagnosing it, as well as with being able to treat it and being able to track, the recovery from it. And so we're diving in more with respect to the REL data, the SDOH data, the SOGI data that I described, and a whole bunch of work that we're doing now at the direction of the Secretary is trying to identify a way of getting greater consistency across HHS and ultimately, hopefully, the federal government in how we're able to get alignment of things like collection of race, ethnicity, language data, collection of SDOH data, collection of SOGI data. Because one of the great things about this administration's priorities is that every agency now has this as a top priority. The flip side of that is that every agency is pursuing their own strategy for how they collect REL data, how REL data is represented, how is SDOH data represented. We believe that we should be focusing on the standards that are already out in the market and that provider organizations are already required to support as a basis for that, and then starting from there. So anyway, that's a number of things that have come from both from policy as well as from COVID.
Thanks, Joe.
Yes. Well, a couple of issues in terms of COVID, how it affected us. Number one, a lot of what we do is collect data. Well, when the pandemic hit and offices closed down, that created a lot of difficulty in trying to collect data. For instance, again, to talk about MEPS, the method is that we have in-person interviewers who go out through the country. It's a national sample, and they actually go to people's houses and, with a laptop, and the questionnaire is loaded on a laptop, and they ask people the questions in their homes. Well, with the pandemic hit, that was out the window. We couldn't do that. So you had to figure out, well, what are we going to do? We can't actually interview people that way. So, basically, we used to limit our phone interviewing to a very small percentage. Of course, at that point, it became everything was a phone interview. We're now actually starting to get back out in the field, but it took a long time. Also, like on the insurance component survey, where a survey of establishments, which is done by the Census Bureau. Well, when the pandemic hit, the Census Bureau shut down all their operations. So that was a mail survey. But if the offices aren't open for the people who are going to send the mail out, it doesn't happen. And so, we had to deal with all those kinds of issues on HCUP. Again, we rely on all of the state data organizations to send us information. If their offices are closed, that's a problem for us. In terms of sending out data, if for confidentiality purposes, you have to have it delivered in person, and nobody's in any offices to deliver anything or receive anything, you have to shut down there. So, we had to figure out how to deal with that. And surprisingly, even with all that, in the last year, we actually were able to get out all our public use files within a month of when we would have normally done it. But it really took a lot of adjusting and doing new things and figuring out new ways to do what we're trying to do. And in a way, that's actually was good, because necessity is the mother of invention, right? So we actually started to do some things that we had maybe thought about looking at, like web-based interviews, or more phone interviews, or as I said, the MEPS is a rotating panel design, and we follow people for 2 years. Well, when we started, it's hard to get people to start with the survey if you can't talk to them. And so we actually held over some panels that we were already with that could be done with phone interviewing, which allowed us to actually, we'll have information on individuals from prior to the pandemic, the period during the pandemic, and then after the pandemic. So actually, analytically, it's a gold mine. But we would not have done that if it wasn't for COVID. I think the other thing that COVID pointed out was that, as Micky talked about, there were a lot of gaps in the federal data resources, and not just in the resources, but sometimes the resources are there, but our ability to actually access them are a problem. And so, we needed to find ways of filling the gaps, getting more timely data, having the detailed data that we needed. And, we're making, again, a lot of adjustments. There was a real recognition across the federal government and the executive orders that Micky had talked about, that he's the head of one of the groups, looking at ways of improving our data resources and our data throughput and what we can do, the public health data systems, as a result of this. There'll be a lot of recommendations for change, for filling gaps, for ways we can improve the system, for ways that we can make things more accessible. So with that, I'll turn it over to Allison.
Craig, I'm happy to give a quick update on COVID, or we can dive into some questions, however you want to handle it.
Yeah, why don't we do a quick update on COVID?
Sure. So just
programs.
Very, very quickly, and I talked about COVID a little bit earlier in terms of data collection and how we use our data and dissemination. But I think one of the other things that's really risen to the top with us is how quickly we can get our data out. And, we have administrative data, we have survey data. Joel talked about MEPS. We run the Medicare Current Beneficiary Survey and went through the same experience of transitioning from in-person to the phone. But with most of our administrative and survey data, we like to have it collected. We like to give it time to mature, and then we get it out. And with COVID, that really wasn't possible. And so we've been releasing a Medicare snapshot on COVID cases and hospitalizations, as well as a Medicaid snapshot. We've released some public use files from our NCBS about the experiences with the pandemic. And we've been able to get those out way faster. Putting notes in front of people and saying, this is preliminary data, we're still collecting it. But it's been really important to kind of promote those discussions about disparities that Micky talked about earlier in terms of who's getting COVID, who's getting hospitalized within the Medicare program. And so I think that's one of the things that we've just taken away from this experience, is how important it is to get data out as quickly as possible while recognizing the limitations and being very upfront about them.
Great, thanks. So we certainly filled the hour, but I noticed there were a couple questions about encouraging the public to have trust in your data. So maybe we could just quickly have some responses to that. And Norm, I see, provided our speakers' email addresses for follow-up questions.
I'm happy to start, and just building off my last response. I think in terms of trust, it's really about being clear and transparent about the limitations of the data, about the quality. Another perfect example of that is the Medicaid TMSIS data that CMS makes available to researchers. We have a data quality atlas that is out there in the public and says, for this state, the quality of data in this area is, good versus medium versus, be careful what you're doing with this data. And so I think a lot of it is just about having that information, having that transparency, and letting users make the decisions themselves for when they can use the data and when they can't.
Yeah, I would.
Oh, sorry, go ahead, Joel. I was just looking at the question, and just specifically, as it relates to the, what the person asking the question was about, for electronic health record information, things like that, HIPAA already gives, a right to correct your records. So the pathway is already there. We are working from an ONC perspective, and how can you make that more electronic and easier for patients to be able to do. So that's a part, certainly a part of the roadmap. Some vendors already offer it in their portal. You can make error corrections, but certainly in terms of a patient's rights, you absolutely under HIPAA can correct your records. So that's certainly something to push on. More generally, though, I would say that we certainly believe that having individuals have more access to their information is the best way for them to be able to, for us to have more accurate information, because the individuals themselves are the ones who know the information, and having the ability for them to access and know it's there and then be able to point out where there are errors is the best way for us to both embody trust and get more accurate information.
And
Joe?
I was just going to say that, this is an issue for the large national databases. I think there are massive QC benchmarking, quality control efforts that go into those before they're released publicly. But that takes some time. And I think, as Allison was saying, you're actually, there's, one is the quality of the, one issue is the quality of the data. The other is the timeliness. So if you're going to put stuff out quickly, it's not going to go through all of those QCs. And it may not be as representative as it would otherwise be. I mean, one of the things we do with our data is, make sure that it's complete. Sometimes you have to do imputation or certain kinds of editing. All of that takes, a period of time. So, and I think over time, people have confidence in those data because they know that all of that is done and they've been released and people have seen them and been able to look at all the data. But, if you're going to release something very quickly, you have to recognize that it's not going to go through those kinds of, QC and benchmarking efforts. And you have to accept that it may or may not be completely representative. There may be mistakes in it, et cetera. So, those are, two issues that you have to face when you're trying to figure out what you're going to put up. Do you want something that's got that has you can use immediately, because you can't wait, or do you want something that's gone through all the QC, but is going to not be, it's going to be from, last year or 2 years ago or whatever.
Great. Thanks, Joel, and thanks to each of our panelists for a great discussion. I think the NAHDO attendees were very interested and engaged in what was discussed today, and we look forward to future collaboration and participation among the state health data organizations and the federal agencies that are such vital stewards of our data. Norm, I think we can turn it back to you.
Thank you.
Thank you.